Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today the topic of discussion is about Lebers Miliary aneurysms. Now, this is the case shared with us by our medical and uveitis consultant in King Saud University, Dr. Abdul Salam Diab. Let's have a look at this case. This is a 35 years old male patient who presented with in OPD with vision right eye 20/20 and left eye 20/100 with pinhole. IOP was normal and anterior segment was no findings, non-significant. But on the examination in the left eye, there were widespread hard exudates occupying the peripheral areas with hemorrhages. So this is the first slide. Please have a look at this. You can see that widely dispersed hard exudates throughout the peripheral retina in the left eye, and along with that there are hemorrhages over there, which are pre-retinal hemorrhages, and at some locations you can also see the intraretinal hemorrhages. Another slide here, you can see that along the infratemporal arcade there are hemorrhages, and also the exudates going to the macula and the mid-periphery in the left eye. This is another slide. Here you can again see the view that the portion peripheral hard exudates like miliarily. Miliary, basically a word you can say that is seed-like, small seed-like, which are dispersed over their hard exudates. So it is typically that appearance which is shown over there, with some scattered hemorrhages and vessels tortuosity at some locations can also be seen. Another slide showing hemorrhages, a macroaneurysm, and hard exudates. Another view, here you can see how extensive along the inferotemporal arcade the blood hemorrhages are there occupying the area, and even the inferiorly the blood vessels abnormalities can be seen. But if you see the posterior area is pole, which we say is not that much affected. So this is usually typical of the ciliary, this one Lebers Miliary aneurysms. There is a disease of mid-peripheral areas and peripheries. Yet another view, the same hemorrhages over there along inferior temporal arcade, and along that if you go in the periphery you can see those seed-like deposits of hard exudates. And even in the macula there is something like star-like configuration, small droplets over there you can also see. This is the right fundus photograph of the same patient. Here you can see no abnormality, no hard exudates, no hemorrhages like that. So basically this Lebers Miliary aneurysms is basically a unilateral disease. Only one eye is affected. So the right eye of this patient, which had the 20/20 vision, there was no abnormality in even in anterior segment and posterior segment. Both were normal. No such thing like that. This is the fundus fluorescein angiography of the same patient, left eye. Here you can see that the abnormal blood vessels along inferotemporal arcade, they are filling up with the dye, and where there are hemorrhages, basically inferotemporally, you can see the blocked fluorescence, and all over there where the hemorrhages, you will see some blocked hemorrhages, blocked fluorescence. So this is the first slide of this patient of fundus fluorescein angiography. This is another fundus fluorescein angiography slide. Here you can see how dye is filling up different locations and small, any widely dispersed areas where a small leaking of the blood vessels, the aneurysms are filling up, giving hyperfluorescence, and the dye is diffusing over there in the retina, the leakage over there. Multiple areas you can appreciate here. Another fundus fluorescein angiography. Here you don't see that the typical filling of the aneurysms which was shown in the earlier slide, but here basically you will see that a blocked fluorescence because of the hemorrhages infratemporally, and abnormal filling of the dye in the inferiorly along the infratemporal arcade. So this is just a representation of the earlier clinical fundus photographs. This is the OCT of the patient pre-treatment. Before the treatment, this is the OCT. Here you can see that subretinal fluid extensive, and even intraretinal fluids you can see, and because of that the patient has got macular edema over there in the left eye. Necessary investigations which are required, we started the treatment this patient, and laser photocoagulation, which is a recommended way to treat these abnormal blood vessels, aneurysms. It was done. You can see in this slide different areas where laser burns have been applied, and you can see their whitening effect over there. This is one photograph post laser. This is another. Here you can again see that laser burns applied, how the aneurysms, the leaking areas, guided by fundus fluorescein angiography, they have been used, and that those leaking vessels are being occluded, laser burns are applied, burns are trying to close over there. So this is the another photograph you can see. Patient, more extensive burns in the peripheral. In the peripheral areas, extensive burns have been applied, and you can see over there. And there is also, you can see a ruptured macroaneurysm, which is leaking superiorly in this photograph. Otherwise, the same miliary distribution of the hard exudates in the periphery, just like seeds or raindrops like this, you can say, which is occupying there. After laser treatment, as we showed you in the earlier slides, the macular edema has settled down. It is shown in this OCT. There is no more intraretinal fluid, no more subretinal fluid. But on the right side, these white dots basically are the remnants or dispersed hard exudates. It is showing the hyperreflectivity intraretinally. Otherwise, there is no fluid or edema, and things have settled down. OCT of the right eye, you can see retinal thickness is the central 207, no macular edema, nothing. As I already mentioned, I already showed you in the first photograph that the right eye is normal eye, no abnormality, and this disease is unilateral disease. Let's talk about the history of this disease. In 1908, Dr. Coates was the first person to describe these types of the blood vessels, telangiectasias, and later on in 1912, Dr. Lebers documented another case and presented, and he showed that retinal degeneration with multiple miliary aneurysms were present in his case. It was up till 1956 when Dr. Rees finally came with an idea that Coates disease and Lebers Miliary aneurysms were the same condition but in different stages of evolution. And both diseases were named retinal telangiectasia by Dr. Rees. This disease is basically primary retinal telangiectasia, idiopathic, unilateral, and male predominance. Predominantly males are affected. There are multiple miliary aneurysms with intraretinal exudates. There is absolutely no other systemic or ocular association. Many people believe that this is the same disease as the Coates disease in children. This disease is shown up in adults. As being shown, the aneurysm are there, so it has been also discussed. The pathology is again that one same, and that is the endothelial cells abnormality. They develop the aneurysms, and because of those aneurysms, there's leaking over there, and hard exudates, and all these things get deposited in the retina. So many believe that the endothelial cells are the main culprit in this causing the disease. The treatment is the same which we did, laser burns, applied on the leaking areas. If it is very anterior and you cannot reach over there, then for those very anterior lesions you have to apply the cryo. If we talk about the injections, intravitreal triamcinolone is another option to control the macular edema. Antivascular endothelial growth factors can also be tried. If there is retinal traction, because there is hemorrhages over there now, if you start finding the tractions or epiretinal membranes, then you have to take the help from the vitreoretinal surgeons to get it done. So these are the various different available options. But this disease is not very common disease, but one of the possible cases that you may encounter. So these patients can also undergo observation for a period of time. For example, if there is areas of telangiectasias in one isolated areas or to one area to up to one quadrant even, we can say, and these things are innocuous over there and they are not causing any lipid exudation, then these patients can be observed on 3 to 6 months basis follow-up. And if we talk about the prognosis is usually good until and unless the fovea is not involved. Because as I told you earlier, the lesions are outside. The lesions are not coming in the macula that much, except occasional I showed you. But the problem is when the disease progresses, the edema, the fluid, the subretinal, intraretinal fluids, and later on I discuss distractions, these things when involve the macular area, then vision is compromised really. So complications can happen after these things, which may be, as it is a vascular abnormalities now, so you can have thrombosis, blood coagulation over there, new vessels can find in the ischemic areas, hemorrhages even can be so much that it can get involved into the vitreous, and then same manifestations like Coats disease can develop in this disease also. So usually not that much, but once the macula is involved, the central area of fovea is involved, then the problems start happening over there. So people believe this is the Coats disease of the adult. They also call it the Coats disease of the adult people, males mostly. That was the case I wanted to discuss with you. This is the literature review. You can find further if you are interested to read about it. These are a few articles, will help you a lot in understanding and its treatment modalities. And I also want to thank you for your attendance and your attention. Thank you.